I guess maybe the first interesting topic would be the angiogram and how well the angiogram works in finding the plaques that are going to cause trouble. I know you used it in your 2000 paper on complex lesions, and you got a lot of valuable information out of there. What do you think of its potential for vulnerable plaque detection?
You know, the angiogram has been the workhorse of both diagnostic and now therapeutic interventional cardiology for over 50 years, and it has led us into the promised land of changing the way we treat patients with coronary disease. And for years, we focused on these critical narrowings, and that we associated with flow-limiting stenoses, and pretty well the angiogram did a good job. If you saw a tight narrowing greater than 80%, you could be pretty confident it was limiting flow, and if it had features that were unstable, where it had filling defects and ulcers, you could be pretty confident it was an unstable plaque. If you saw an area of the vessel that looked normal or had a less than 30, 40, 50% narrowing, you could be pretty confident that the vessel wasn't very significantly diseased and that the narrowing you saw wasn't limiting flow. But over the past 10 years, we've begun to understand that the angiogram has great limitations. So on either end of the spectrum, when there's no or minimal disease, we don't worry about flow limitation. And when it's severe, we pretty much know what to do in terms of treatment. But in the wide in between, there's a lot that the angiogram doesn't provide, both with respect to two fundamental issues of how we treat patients. One is, how do we do a better job in the cath lab in patients in whom we're going to intervene, and how do we do a better job at making sure that we treat the right lesions, treat all the right lesions that are going to benefit the patient, and then get the best outcome in the cath lab and subsequently from our treatments with stents. And then the larger question, what do we do in terms of finding those plaques that you have helped us understand are vulnerable, that look unimpressive by the angiogram, that are not narrowed in particular, that are not flow limiting, that may serve as potential for a future heart attack or sudden death. And so we need to move beyond angiography alone, because angiography alone is not enough to achieve optimal outcomes for percutaneous coronary interventions, and angiography alone is not sufficient to detect those plaques that are going to be problematic in the future and cause these potentially calamitous events of heart attack and sudden death. Well, let's go back to the fundamental question about, is angiography sufficient? And what angiography misses is it grossly underestimates the presence of atherosclerosis, it grossly underestimates the magnitude or extent of atherosclerosis, and tells you very little about the composition of the plaque.